Yeah.
Hopefully not the shores.
All right. Good afternoon, and thank you for joining the RLS Foundation's webinar titled Causes of RLS. My name is Adriana Colucci, and I'm the Administrative Assistant at the RLS Foundation. The RLS Foundation is using Zoom webinar for this and all future webinar events. To ensure seamless webinar access, confirm that your Zoom app is up to date with the current software. If you need help accessing the live webinar on your computer, call the phone number listed on your registration confirmation email for assistance. If you have any other questions, please email clara@rls.org. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Becker will answer as many questions as time allows following his presentation. After the webinar, the recording will be made available in the member portal section of our website on the next business day. If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Philip Becker. Dr. Becker is the founding partner and retired president of the Sleep Medicine Associates of Texas, PA, and served as medical director for the Sleep Medicine Institute at Texas Health Presbyterian Hospital of Dallas for nearly 25 years. Dr. Becker served as a clinic professor in the Department of Psychiatry at UT Southwestern Medical Center in Dallas until his retirement in 2019. Becker is an active member of the RLS Foundation's Scientific and Medical Advisory Boards, Opiates Committee, and Quality Care Certification Committee. Thank you, Dr. Becker, for sharing your time and your expertise with us today. I now invite you to begin your presentation.
Thank you, Adriana. Well, causes of restless leg syndrome. And it's my hope that by the end, you'll have an understanding of the hypotheses of what causes RLS. We'll review neurochemistry, receptors, and RLS, as well as how it might all apply to your RLS therapy. You experience those ups and downs of restless leg syndrome. This is certainly something of both up and down in bed, but also this is an example of what the chemistry of the brain may do in regards to RLS. And what are the players that we have here? The players of restless legs include the strong man, Iron Man. So iron is understood for its important role. I like to say, well, if I was a young teen, perhaps this would all be dopamine dope. This is not the illegal dope, but the dope of dopamine. And with that, I have to admit our interest and publications about how dopamine agents can help restless legs kind of made us a little dopey, and the doctors made the errors that led to augmentation of patients' symptoms of restless legs. I've used glue to describe glutamine, the other brain chemical that's important to both RLS, anxiety, and mood disorders. And then finally, research that has been done on adenosine. And this is what I call the beautiful compound that has been described more recently, the adonis molecule that is there influencing dopamine and glutamate. As well, there are the opioids, mu opioids, the opiate agents, the GABA agents, and the alpha-2 delta channel calcium agents. So the keys that for all of you that I would ask you to think about is your iron status. Ideally, a measurement of your blood ferritin level would be above 75. RLS augmentation, if you're on dopamine agonists, dopamine agents, which we'll go over what those are, reducing the use and the dose of these agents will lessen the chance for augmentation or make it less of a concern. We want to also avoid abrupt discontinuation, as there is a withdrawal syndrome of dopamine agents. Timing of therapy based on an agent's onset of action and length of benefit. We need to understand how the drug works in the body. So when we have a chance to talk with doctors, doctors need to remember urges, those things that you know very well. URGES, and U represents the urge to move the limbs. R, rest worsens the sensation. G, getting up and going is good, meaning that temporary relief with movement occurs. Evening and night worsening. So these URGE are the symptoms to arrive at a diagnosis. And we added, after a few years, the S. So for urges, because S stands for sole or principal explanation of the symptoms rather than comorbid conditions that might be present. Historically, here is what we can talk about. In 1670s, going back those many years, Sir Thomas Willis, as was at his time a discussion of balance of humors that were causing restlessness. And with that, he did, though, offer an opium derivative, laudanum, to a patient who was in the place of greatest torture and had relief of their torture of their legs. In the subsequent centuries, there were only a few publications until 1945, when Carl Ekbom from the Karolinska Institute in Sweden provided the first modern descriptions of restless legs and the importance of iron and opiates, as well as other things. And so at this point, it ushered in more understanding. And in 1970s, there was a first effort to educate doctors about sleep. It was called Project Sleep. And the recommended treatment in Project Sleep was the anti-anxiety medication clonazepam. And there was one slide that said, avoid levodopa. Well, I think it was probably recognizing the worsening that occurs with RLS on augmentation. But with that, there was a Turkish physician, neurologist, movement disorder specialist in 1982 who described the benefit for his patients using levodopa. And over the next years, the dopamine hypothesis began to develop. By 1990, iron regulation, again, return to Dr. Ekbom's interest. Iron regulation, the importance of having ferritin levels above 50. Now we know it should be 75 or 100. And then also in the start of the 21st century, the use of iron as therapy through the IV, intravenous. And then between 1995, 2018, there was a dopamine receptor study, D2, D3, and then more recently an interest in D4 receptors, although we don't have any medications that specifically affect D4. During this time frame, the approved Food and Drug Administration agents of Mirapex, Requip, and Nupro patch were approved, but also we began to increasingly understand how augmentation was the significant potential complication of treatment of RLS. By 2000, I returned to an understanding of opiates as had been recommended by Dr. Ekbom. These are mu receptor active agents. They're kappa can kind of make you a little crazy, so as good as mu. And 2000, glutamate studies began to occur, and also calcium channel blockers, alpha-2 delta compounds. But finally, in 2017, the importance of that beautiful chemical adenosine began to occur. And with that, adenosine was described as having an upregulation of dopamine, a downregulation of glutamate. The agents of adenosine cannot be directly given normally in very special circumstances. So with that, indirectly, we can affect dopamine in the brain with the use of dipyridamole. So this is a rather busy slide that I don't ask you to even have to think too much about, except to say it's my way of saying to physicians, well, each patient has their own factors that they may find of pertinence to their case. So again, you understand the impact of your RLS the best. Now, the features of RLS. It is a brain disorder that impacts the peripheral nervous system, that feeds back from the peripheral nervous system into the brain. And for this reason, it has a sensory component and a motor or muscle component. Even though I'm trying to talk of causes of RLS, we still don't have the fullest understanding of what causes the problem. We know the importance of abnormally low levels of brain iron and the dysfunction of dopamine, glutamate, and adenosine, but still need further understanding. Prevalence, well, it varies from 3 to as much as 10% in different studies, and is based on the severity of the underlying problem, but also by region there is a difference. Age of onset, well, RLS can present at any age, including children, who it's estimated that about 1 out of every 200 children will have RLS before the age of 10. The peak presentation, though, is most likely be between 30 and 60 years, although earlier and late life presentations occur. I've had a couple of patients who were in their 70s when they first had their problem. Gender, well, if we take 100 individuals with restless legs, 60 of them or so abouts would be women, 40 men. And women, well, 1/3 of pregnant women will report in their 3rd trimester symptoms of restless legs. Also, research has shown that the more pregnancies a woman might have, increases the chance that they will complain of clinically relevant restless legs. Now, genetics. Well, lots of excellent work trying to be done. We know that about 60% of cases of restless legs that individuals will report a family member who also has it. It's understood this to be an autosomal dominant presentation. Here are the whole variety of chromosomes that have been found in French Canadians, Bavarians, Italians, Americans. And so with that, even have had, so it's more Northern European, and yet there are cases certainly in Asia where there are reports of restless legs, all of the lower levels, 3, 4, 5%. Now, my understanding of restless legs came at the same time I began practice offering the first sleep services in the state of North Dakota. And with that, I was most impressed that my Swedish, Norwegian, Danish heritage patients seem to have more of a problem, leading me to wonder about, well, is it a Viking migration problem? And so with that, it's just total speculation. Now, there are the motor components, what are called periodic leg movements of sleep that are relevant to RLS. But it's important to recognize that in sleep studies, there are many, many more people who will have been identified as having periodic leg movements of sleep than those who have RLS. And not all RLS patients will have periodic leg movements of sleep on one night, or even sometimes 2 nights of sleep testing. You don't need sleep testing if you have restless legs unless you have other potential sleep disorders. Now, what are the reasons for poor sleep besides restless legs? Well, sometimes they're mixed. Depression is 2.5 times more common in restless legs. Anxiety disorders, including panic attacks, is found to be 2 to 4 times more common in RLS. Just general stress will worsen both sleep and one's RLS. Medical disorders such as sleep apnea have a mild to low moderate increased frequency of sleep apnea. I'm not sure if that's more the fact that people are coming to their sleep specialist, their doctor with sleep apnea complaints, and by questioning get a more chance of having the report of RLS. Pain disorders, fibromyalgia, inflammatory autoimmune disorders also have problems of sleep and increased overall incidence. So we've got the ups and downs of RLS, and we move now to the ups and downs within the brain. So here's the proposed thoughts, hypotheses of how restless legs is present. Iron, dopamine, glutamate, endogenous, meaning internal opioids, not the that which you use by mouth, and adenosine. And how do we study this? Well, this cute little guy is the idea of an RLS model. And so with that, the first proposal was the dopamine hypothesis of RLS by Dr. William Ondo at the Baylor College of Medicine in Houston. And his focus was on area A10 in the spinal cord, and that these long projections from the middle of the brain went down into the spinal cord, out into the periphery, and then fed back into the spinal cord. And there was a communication between different areas of the spinal cord up back into the brain to produce the motor and sensory symptoms that were there. Then the role of CNS, iron, and RLS. And here's my opportunity to honor the Hopkins group, Dr. Early, Dr. Allen, who died recently in the last year and a half, and their special contributions to RLS. And then their colleague at Penn State, Dr. Connor, who did a lot of the basic science work about iron and restless leg syndrome. But then we move to the adenosine, the pivotal role of adenosine that was identified by Dr. Sergi Ferri and his group at the National Institutes of Health, and how this may become moving towards a theory of, not just a hypothesis, but theory of restless leg syndrome, supported by various grants, including from the foundation. And this is a rather active one. A graph. I'm not asking you to understand the graph, the picture, but to say adenosine accumulates over the day and is responsible for slow wave sleep. It's considered the deepest stage of sleep. And that as you increase adenosine activity at the cellular level, you upregulate dopamine release and downregulate glutamate. More dopamine, less glutamate would make restless legs better. And there's this interaction of dopamine and glutamate neurons having this interaction of the various adenosine receptors, A1, A2. Now, the model was a breeding of the rodent who was brain iron deficient. So they had inadequate iron in the brain and was found to mimic the symptoms of RLS. They can't tell us about their sensation, but they have movements that can be seen as the A1 adenosine 1 receptor is disrupted, the balance between adenosine, dopamine, glutamate occur, hypersensitivity of certain areas of the brain can result in an issue. And with that, if one uses the common medications of pramipexole, propranolol, gabapentin in the rodent model, it can significantly and completely counteract glutamate release. And yet we can't use adenosine directly. We don't have A1R agonists that can be safely used, but we can use a indirect compound, and with that it was dipyridamole, and a study by a Spanish group led by Garcia Barrero were able to identify that dipyridamole in 13 patients, 6 of whom showed major improvement, 4 more who provided partial improvement, although it did not eliminate the problem of the RLS in the patients. So moving now to management. I know this is of great interest to many of you. So to doctors, I say, target this, the dysesthesia, the uncomfortable sensation to the lowest level possible. That's the goal. Sleep should be normalized. Periodic leg movements reduced so that both the patient and bed partner report that there is significant improvement. Timing of treatment is important, being sure that you catch it before the symptom becomes significant. And side effects of medication should be minimized. Now, for you, this is a handout available from the foundation about RLS triggers that you are going to have to understand for yourself how triggers may be present. Common ones include smoking, alcohol, particularly as alcohol gets out of the system, caffeine, and extreme exercise, to the point of over fatigue will trigger the RLS. But other common triggers that have been reported by patients in surveys are carbohydrates, refined sugars, food high in sodium. I particularly find it interesting when someone says that Chinese meal causes them a problem because of MSG, monosodium glutamate. And then we've also discussed previously the emotional stress factor. Agents such as the over-the-counter Benadryl, the over-the-counter sleeping agents such as anything that has PM after it, and melatonin, which causes a rise, an effect on things such as dopamine. Melatonin best taken below 3 milligrams rather than the higher 5 or 10 milligram dosages because of the potential higher doses will cause increased RLS. And then again, many antihistamines, unless they don't get into the brain, antipsychotics, also called neuroleptics, and antidepressant medications can cause a worsening of symptoms. Again, you're the best judge. Now, what can be done to be helpful? Alerting activities in the evening. Playing a game. It doesn't have to be Super Mario, but it can be any game that will engage you and you can do in a properly enjoyable manner. Puzzles may be options that seem to be distractions to help. Caffeine, chocolate are best ended by noon. Why is that the case? Well, caffeine can last up to 12 hours in some people, and caffeine blocks adenosine, causes the adenosine levels to fall. It's a adenosine blocker. Exercise, well, I was saying before, over-exercise makes you worse. Well, becoming more fit, though, allows you to seem to tolerate your RLS better, may lessen the overall symptoms that's been seen in studies where exercise was gradually increased over 4 to 8 weeks. And with that, just a picture of a chair exercise cycle that can be used as you watch television or read. Counter stimulation. Most of you probably have some of your own discoveries about what counter stimulation might be helpful, whether it be massage, bath, rubbing, evening activities, vibration pads, and many other things that might make a difference. We also would encourage physicians to be aware of and treat secondary causes of RLS, iron deficiency, blood loss, renal failure, a real misery for those on hemodialysis when they have restless legs, neuropathy, pregnancy, opiate withdrawal post-surgery. I don't know why pregnancy is there for treatment. I think about it. Iatrogenic eliminating offending agents such as antihistamines, dopamine blockers, such as the antipsychotics, anti-nausea medication, metoclopramide, Reglan is the one that is often an offender, and then antidepressants of the serotonergic class or tricyclic agents. Iron therapy. Well, we know the importance of iron in the brain. Transferrin, ferritin, and iron are all things to be measured in the body, with the most common one being ferritin as initial, and then as you offer iron therapy, you want to know about transferrin. Oral iron is most commonly given as ferrous sulfate, 325 milligrams. That will have what's called elemental iron, 65 milligrams, taken 3 times daily with a lower dosage of vitamin C. The problem of oral iron is a bit slow in uptake, and in fact, you may only absorb 1 or 2% of oral iron unless you're very significantly deprived in the body of iron. This led to, in the most severe cases, the use of IV iron. The most common one is this ferric carboxymaltose, and with that, when given, is best tolerated in those who have a significant abnormally low iron levels. Response to iron therapy has been reported to be between 60 and 90%. There is some degree of improvement, although as far as resolution of RLS is if it happens, it is infrequent, and the need for repeat iron may be present. If you are interested in more information, consider this webinar given in 2018 by Dr. Early on the biology of iron. Now, medication, I've spoken already about the idea that the timing is important. We know that restless legs has a circadian presentation, meaning that according to the biologic clock, it is most common between 4 p.m. and 4 a.m., unless a particular person is very severe or has developed augmentation, then it can occur well into any time of the day. And yet for you, it would be important to determine the hour of your average RLS onset that you know it becomes bothersome. And so before you have the bothersome, you want to take the medication at a time that's right. And so with that, you have to understand how quickly it gets into the body, the onset of action, the peak plasma levels, reaching their best therapeutic benefit, and taking the medication so that it peaks the time of your onset of RLS. And when you know when to take your medication, typically 1 or 2 hours before you might need them, you set an alarm to tell you it's time. Here is it all laid out in these various papers by different organizations. And with that, by 2018, we had these recommendations that alpha-2 delta ligands should be considered to be the first line of therapy. In a moment, I'll say what those agents are. Comorbid pain, anxiety, insomnia are improved with these agents as well, therefore most appropriate. If someone has had problems of impulse control disorders or addiction, you want to avoid dopamine agonists. Very severe RLS, though, maybe the first line should be the agonists or comorbid depression and dysthymia. Dysthymia kind of is just a sad mood. And with that, the use of dopamine agents have also been used as adjunctive therapy in the treatment of depressed mood. But the reason for dopamine agonists for those who are obese or have metabolic syndrome, diabetes, with that is because the alpha-2 delta compounds, those ligands, will cause potential weight gain, sometimes up to 15 pounds. So what are the alpha-2 delta calcium channel blockers affecting how the nerve sends signals? And the gabapentin anacarbol is the one approved alpha-2 delta compound. The brand name is Horizont, while gabapentin, pregabalin, both of those are in the body at about 2 hours. So you'd want to take them 1 to 2 hours before you really need the therapy, while gabapentin anacarbol, the anacarbol affects how it gets into the body, the absorption through the gut. And with that is taken just before supper time, maybe with a light snack. Typically, it's recommended at 5 p.m. so that it's nicely there by the time you're ready to come to bed. And then because it continues to be absorbed throughout the intestinal tract, it will be available for many more hours. Now, the dopamine agonists include pramipexole, Mirapex, ropinirole, Requip, and the rotigotine patch Nupro. Pramipexole, well, and ropinirole 1 to 2 hours before you really need it. And with that, you'd want to do with the reticuline patch for more significant symptoms, perhaps even occurring early as 4 p.m. This is a 24-hour patch that is put on, and it takes 3 to 5 days to get an adequate blood level. But after you're there on the 5th day with an adequate blood level, it will continue. Now, levodopa. There is a role for Sinemet levodopa because of its rapid onset of action. So it can be quite helpful if you're in a concert, movie, on an airplane. So with that, we do recommend, though, that you would never want to use more than 300 milligrams to minimize the chance of augmentation. And the diagnostic tool can also be used with this in the sense that the levodopa, when you've got other possible sensory disorders, let's say a neuropathy, is this an RLS or neuropathic pain? Well, if you give the Sinemet levodopa, it will be potentially helpful in a way that you know, well, this is much more RLS, and RLS therapy is indicated. So our challenge now is when we use dopamine therapy is the problem of augmentation. Here's the formal diagnosis. If your symptoms have moved 4 hours earlier, you've got it. If it's 2 hours earlier, but with that, what we have is the short latency to symptom when at rest. Other body parts started in your legs, now you have it in the arms, even infrequently in the face. The intensity comes on much stronger, and the relief from treatment is less. You have real questions about this, please go to the Foundation's handout about RLS and augmentation. So the features: 27 to 85% of people with restless legs can develop augmentation with a greater chance to levodopa over pramipexole or ropinirole in the 1-year time frame. It's distinct from just the underlying RLS problem getting worse. It reduces ferritin level. If you're less than 75 micrograms, you're probably at a potential increased risk. Rebound symptoms occur at the end, are similar to this question of augmentation. And this is not tolerance to therapy, meaning you're not responding. Your brain doesn't respond in the same way. There are specific factors to be considered, which I don't have time to discuss. Now, augmentation, levodopa occurs more quickly and more frequently. Pramipexole, ropinirole, a little less, but still within months, while opiates, gabapentin, do not have augmentation. But we also have to be concerned if you say, oh, I need to get off this dopamine therapy. There is the potential for a withdrawal syndrome that has both psychological components and physical components. Severity and prognosis is highly variable. Some will have potentially protracted symptoms, and that may make it very difficult to get off, even potentially unable to do so. Impulse control disorders seem to increase your chance of having this withdrawal symptom. We'll talk a moment here about impulse control, and that for this reason, a provider should use caution in the use of the dopamine agents, warning you about the potential problem, and to follow patients closely for any withdrawal symptoms as trying to taper down on the dopamine agonist. What are the compulsive disorders that are associated with these agents? Compulsive shopping, gambling, eating, hypersexuality can all occur. Punding is the idea of ordering in an obsessive way, and trichotillomania, hair pulling, has also been thought to be a factor on dopamine agonists. Now, opioids, they treat very well the sensory component in many, and less so for some of the motor components, the muscle movements. The mu opioids are the ones that are the most effective, but there are the complications of constipation. Infrequently, there is an activation, not an activation of the restlessness so much as it is an activation of just the body. And the concern with the use of opioids is that breathing in sleep, that's both obstructive sleep apnea and the brain signaling of central sleep apnea, can be made worse. So the higher the dose, the more the problem. Therefore, lower doses are better. And luckily, lower doses are more commonly effective, so we can lessen the potential bad effects. But addiction and dependency is considered to be uncommon, perhaps even very uncommon. Here is what's been laid out for doctors and how to appropriately use opioids for refractory restless legs. And with that, in the summary statement, opioid use is selected in selected patients with refractory RLS may be life-transforming with favorable risk-benefit ratio. I mean, it can be very helpful, and much excellent information is available through the foundation. The presentation given by Dr. Early on the role of opioids in RLS. The presentation in May of 2022 was about RLS opioids and the study that's being done at Harvard by Dr. John Winkelman, and then their recent Odyssey 2 survey webinar provides further information about opioid use. And one of my last slides, I wanted to say, well, continued research is occurring, interest in various things that might be helpful. Here's this long list of things that might be tried or have been tried in very small case series that might have a role. So there's ongoing hope of what may be beneficial. And in summary, we have the neurochemical players of RLS. Iron Man, the strong man, iron, the dopamine, glutamate, the potentially increased role, the beautiful thing that might be happening if we're going to address adenosine, the opioids, the GABA, the alpha-2 delta calcium channel blockers. And at this point, I hope that even though we've talked about the ups and downs of restless legs, I hope that you'll find that there is potential benefit for you in what we've talked about. Very good. I turn it back to you, Adriana.
All right, thank you so much, Dr. Becker, for your very thorough and very informative presentation. We're going to go ahead and start answering some of the questions that were submitted in the registration process. All right, so the first one we have is RLS a brain disorder or a nerve disorder?
Yes and yes. We think that the brain, the central nervous system, is a pivotal role, but there is this interaction between the peripheral nervous system, the nerves themselves. Painful neuropathies do seem to have an effect upon restless legs. If you damage nerves, there are going to be potentially more issues that would be present, but that the brain seems to be the most pertinent matter.
Okay. Do genetics play a major role in whether you get RLS or not?
Well, the answer to that is yes, and then I add my but. Yes, in a sense, as I had tried to point out, that there are 60% of individuals who report about families. I have an example in my experience with my wife, who has restless leg syndrome, receiving a low dosage of pramipexole. My youngest daughter has a low dosage of pramipexole. My elder daughter had RLS during her pregnancy and has it infrequently during times of stress. And my wife's mother, 3 of her 5 siblings have RLS. And we know that mother's mother had the problem. So it is there. But as far as specifically understanding the genetics are of interest in particular families, but the exact genetic cause is still to be identified.
So if RLS does run in someone's family, can environmental factors such as good diet, sleeping, and exercise habits offset the genetic aspect of it?
I think with that, can we talk about modification? Offset suggests that you can solve the problem, and there might be cases where it would be the case that someone would notice a marked improvement with proper diet, again, the association for some of refined sugars or too much salt as being a factor. For some, caffeine, I think, certainly may be a factor to consider. They're going to be a rare person who tells me that they had to stop caffeine entirely before their symptom was relieved. As to the benefits of exercise, as I've tried to point out, that if you gradually improve your level of fitness, that certainly could make a difference in how you experience your restless legs.
All right, what are some of the potential underlying neurotransmitter causes behind RLS, and which do you think is most likely to be the cause?
Well, I certainly hope that it became clear that the players are important in restless legs. The one that is of great interest right now is adenosine. The adenosine seems to have a type of control of dopamine and glutamate, both things that have been otherwise in the brain identified as being important to restless leg syndrome. So I would say adenosine, but as we're still awaiting agents that might be impactful on the adenosine system that can be safely used to make restless legs better.
Got it. What do we know about the molecular basis of RLS? Why do dopamine agonists work, and why do alpha-2 delta ligands work?
Okay, well, when we talk about those therapies, dopamine, there's an interaction between iron and dopamine within the nervous system. With that dopamine, if we can build on Dr. Ando's work of this area 11 within the brain, providing projections that impact sensation and muscles, that this dopamine effect would seem to be explained, an explanation of what might be relevant. And when we talk about the use of dopamine agonists, well, they're specifically affecting that. There may be effects upon adenosine as well, downregulating glutamate, all that may be of value. Now, the things like gabapentin, the alpha-2 delta compounds affect the calcium channel. And with that, it regulates the signaling within the nerve. And that's why gabapentin is probably most commonly used for neuropathies. It originally was an anticonvulsant, not used that much as an anticonvulsant. But with that, certainly used actively for neuropathy. And we presume the same mechanism of the calcium channel. And there may be other chemical effects, something like called kinase may be affected as well to impact sensation. So with that, we hope that's the case. But like much of what I have to say, more work is needed.
All right. How much of a role does anxiety play with RLS?
Well, I would say that it is a factor, and certainly stressful situations that make you feel anxious may increase your symptoms of restless legs. And when we start talking about anxiety disorders, something that may need to be addressed with various behavioral therapies, medication, that we know that there is the increased likelihood. And if we continue to talk about that glue of glutamate, glutamate is a factor to anxiety and a factor to worsening RLS. So therefore, we would say that there is a relationship. And the multitude of different chromosomes that have been identified in genetic studies that account for a lesser portion, but an important portion of RLS, that these particular agents those area, I'm sorry, the areas of the chromosome that we're talking about, some of them have also an anxiety feature as well.
A doctor told me that RLS is caused by sleep apnea. Is this true?
No, that would be my response to that. Can they co-occur? Yes. Can sleep apnea make restless legs worse? But to say that that is the cause, I think that it was probably a rapid statement by the doctor. Certainly, I would hope almost any physician understands that we're talking about an issue of brain. Now, there are some doctors who confuse periodic leg movements of sleep with restless leg syndrome, and sleep apnea does increase the presentation of the leg movements in sleep. So I guess if that's where the confusion from a sleep study comes up, we're still trying to make sure every doctor understands that they're not the same thing, that leg movements and RLS are not exactly the same, although they have some relationship.
Well said. I did not have RLS until I had Cushing's syndrome. Can excess cortisol cause RLS?
When I saw this question, I said, oh, doggone, this is a curious one, cortisol, because studies have said that increased cortisol is present in people with restless legs, and that decreasing cortisol is present in patients with restless legs. So I guess I don't know what that means yet. And these are all small studies, so that in that regard, the jury would be out. Certainly for someone who has the excessive cortisol levels that occur with the problem. Now, the other issue would be as well, cortisol is, when you have Cushing's disease, you're going to have treatment for the Cushing's disease. And so that may have an impact as well on the balance of various neurochemical systems.
Can alcohol make RLS symptoms worse?
Alcohol. Well, I think to this issue, I have to admit that there's been inadequate study of this. But with the issues of alcohol, I would suspect that the issue is not the initial use of alcohol during that 1 hour when the alcohol is in your system being metabolized. Of course, the more you drink, the longer you're going to have the blood level be elevated. I am of the opinion, just like we know how alcohol worsens sleep, not when you drink the alcohol, unless you have a paradoxical reaction, but that when you drink, as the alcohol gets out of your system, your RLS gets worse. And with that, the problem of withdrawal of alcohol and how that affects the nervous system, kind of activating the nervous system, would make restless legs worse, I would suspect.
Iron tests are recommended to support an RLS diagnosis.
And with that, yes, we would want anyone who a doctor would be considering the use of iron therapy to do that. Yes, there are an issue that iron taken by blood, what's called the serum, most commonly the serum ferritin level, may appear to be normal, maybe above 50 or even 75, but that in fact, the brain iron in the brain, there may be an abnormally low level of iron, resulting in the exacerbation of restless leg syndrome. So knowing an iron level is probably very pertinent for anyone, especially if you're having more challenging control or problems with augmentation, then you really want to do that. And then as you are being treated, knowing much more about one's iron status, including the transferrin, iron binding capacity. And these are kind of the standard tests that would be used if you were anemic with that. And of interest that an abnormal ferritin when one is dealing with anemia is typically below 20. And so most people with RLS don't have ferritin levels that low. They can, but not the majority. And yet they certainly could have a problem. But the strange thing is that there are certainly people who have perfectly normal iron and still have significant restless leg syndrome.
Do you know of any work being done to find the cause for those who have primary RLS, but who also have a very high serum ferritin level?
Okay. Well, a high serum ferritin level is the disorder called hemochromatosis. Those of Celtic descent seem to have an increased potential for this problem of hemochromatosis. It's reported that about, if you take the general population, about 1 out of every 200 will have it, and there is co-occurrence. As to the issues of research, I would have to rely on the Hopkins group, Dr. Early, for his opinion about that. As to the specifics of ongoing regular research, I really have to say I do not know. But also importantly, with hemochromatosis, we're having to talk about what's in the periphery, what's in the brain. Brain levels that fall will result in increased symptoms of restless legs. So one could have high levels in the blood with close to normal levels in the brain, but that fluctuations of the brain levels may result in the symptoms of RLS. So with that, it's an area that I would hope those who are assessing iron are understanding this particular group of hemochromatosis with RLS.
All right. Is RLS a precursor to Parkinson's disease?
There have been a few doctors who have questioned that, proposed that, and the challenge remains that about the frequency of RLS in patients with Parkinson's disease who have been treated with dopamine agents is about 2 times higher. So these dopamine agents, so the normal dopamine therapy for their Parkinson's disease, could it be causing a problem of augmentation? That has always been the question I've had about these reports. But as to an explanation of why Parkinson's occurs, to the best of my opinion, I'd say no. And now there's a real interest in how certain gut flora, the bacterium of the gut, may have an impact upon the presentation of Parkinson's disease. So will that be the case? And who knows? What's called the microbiome of the gut, there could be, some interest in how this occurs. The good Dr. Walters, Arthur Walters at Vanderbilt, has often talked about, how the microbiome might be involved, although again, the research remains inadequate.
Definitely. My femoral nerve was injected during a knee replacement, so a nerve injury. That's how my RLS began. Have you heard of this before?
Have I heard of that before? I have to admit, no, I have not. Would that be something that I could say, if we're understanding how the spinal cord and what's called the gating features of sensation and movement are related, the femoral nerve certainly could have an impact upon the issues of restless legs. So I could foresee that there might be an issue. Certainly, we would hope that there would be potential benefit from the alpha-2 delta compounds. With that, certainly is a significant misfortune to have that. What's medically called an iatrogenic injury from having that injection.
All right, last question here, and you touched upon this in your presentation, but when was RLS first treated as a health condition, and what was the earliest treatment?
Well, from a historical standpoint, the other name for restless leg syndrome is Willis-Ekbom's disease or disorder. And with that, this particular problem of restless legs, what we would certainly, according to the description given by Sir Thomas Willis in a paper from the 1670s, and again discussed in another 1694 treatise, that this would be present. His explanation was the balance of humors. I don't know if he was bleeding people to balance those humors if they had this particular problem. But with that, Dr. Willis, Sir Thomas used the opium derivative laudanum as a way to do therapy. And then the term through the 1880s in a few papers out of France was anxietas tibiarum. And then finally in 1945, the modern era of investigation began with Dr. Ekbom and trying to say opiates and iron were important in regards to the disorder.
Great. Thank you so much, Dr. Becker. That concludes our question and answer portion for today. Our next webinar will be hosted on Thursday, July 20th. Dr. Kunal Agarwal will be discussing RLS and comorbidities. Visit www.rls.org to register and attend. Thank you to everyone who attended today's webinar, and have a great day.